When my husband experienced chest pain, I knew he had to go to the ER at Fairview Park Hospital because it had an accredited chest pain center. Chest pain isn't like a broken arm or a high fever. They treat chest pain like the serious condition it is, and they treat it fast. And it was a good thing we knew the difference because my husband was in cardiac arrest.
Oh, I was fine.
Now he is.
Treat chest pain like chest pain. Choose the ER at Fairview Park Hospital.
Hi everyone, we'd like to welcome you to Real Talk. I'm your host Pat Terrio, and we are here at Fairview Park, and we're here at the Cardiac Rehab Center with a wonderful, amazing woman herself, Miss Gwen Upshaw. We really want to feature certain and different nurses so that you'll understand and appreciate how amazing these men and women are. And so, Miss Gwen,
Yes, ma'am.
how are you?
I'm doing fine.
We're kind of at your disposal this morning. Kind of want to really talk a little bit about you. Tell the people about you, and we know you're a grandma
I'm a
and
grandma, I'm a mom, and a nurse, and it's 24/7.
24/7. Now, so you're a cardiac rehab nurse.
Yes, ma'am.
Tell us about that.
I've been a cardiac rehab nurse since 2009. I came over from the critical care unit, so I have seen both sides now, and which is very impressive. You know, they come in through the front door, and we get to see them heal, which a lot of times over at the hospital you don't get to see that. But I've enjoyed it. We've worked together as a team over here, and we get it done. And our census is slowly picking up again, and that's good. Holidays usually set people back, but that's family time too. So.
And you know, it's such a delicate time when you get patients. You know, when you're talking about cardiac rehab, these people, they've had heart attacks.
They've had heart attacks. They've a lot of them that you can have two different types. You can have what they call a STEMI, ST elevated MI, or a non-ST elevated MI, which both of them can end up either in having angioplasty or with a stent, or with a stent. Or open heart surgery, which is called, we nickname it as cabbage, but that's open heart surgery. People that have valve replacements, we have them come through as well. And we have a new diagnosis, which is congestive heart failure.
Okay. So we want you to kind of walk me through as a new patient, I would say. Do you call us patients?
Yes, ma'am, I do.
Because you know sometimes
Sometimes it's clients and patients, but I'm the old term because I've been around a while.
Been around.
So I just stick with patients.
All right, so let's kind of walk us through the process of what you would do if I was a patient coming in, okay? So tell us what we do.
As you come in, first we get the referral from the physician, and we make sure that the insurance is covered, the program, and then we get you set up for a assessment today.
Okay.
The assessment usually takes about an hour and a half to 2 hours. We do all your medical history, we check your vital signs, we listen to your lung sounds, check your pulses and everything. Then we check your pain assessment as well. Pain can be chest pain or it could be joint pain, because we're going to be working you out on the equipment.
I'm about to work out.
Yes, about to work out.
All right. So we're doing the assessment, and what's next? What do you need to do?
What do we do after I get all the history and all? Then I'm going to put on a heart monitor, and we'll put the heart monitor on you.
Okay.
I'm going to get a set of vital signs, check your pulse ox, because if you have any fluid buildup or you've got a little bit of pneumonia, sometimes your oxygenation's not up. That's why part of the reason we do the assessment is to evaluate how their lungs are right then, to know if we need to put oxygen on it. A lot of things happen if they've had open heart surgery. You know, you can have fluid buildup, your red blood cells count can be down, your hemoglobin, which can cause problems with the oxygenation.
And you know, people, this sounds familiar to me because actually when I was in college, I was actually having to wear a heart monitor. I developed mitral valve prolapse, and it caused stress and different things like that would just really aggravate me. And so I was wearing a heart monitor in college. You know, so I'm very familiar with that. And even going to the dentist, I would have to take, you know, some type of antibiotic due to that. So I'm very familiar with this. Okay.
All right, so we'll get your vital signs.
My vital signs. It's probably going to be high today.
Probably. And a lot of times when people first come to see us, they do. It is a little bit elevated.
Y'all gonna be like, oh my Lord, what's wrong with that?
For some reason, everybody thinks that we're going to work them out on that treadmill with it, like they do at the doctor's office, and we don't do that.
Y'all hear that?
Yeah, we do it nice and easy.
And you do stress tests.
No, we don't do the stress test
don't do
here.
any?
That's already been done.
Already done.
We're going to start you off very slowly.
You're gonna have to.
Yes. What we'll do is I'm going to get the vital signs, and Kelly will talk with you and get a little bit of more things what you're doing on a daily basis as far as walking, what you're doing around the house. Then we do a little 6-minute walk around the pool.
Okay.
Because we have it measured off out there. And you go at your pace. No, you're not trying to run a marathon. You're just going at your pace. We just need to know if you're getting short of breath. Is that pace causing you to have chest pain? Does it hurt your knee, your hip, your back? What's going on?
This is going to be a great assessment for me.
That way we know what piece of equipment, when we look at all that, you need to go on.
And all of this is within that 1 hour to 2? Okay, very good. All right, we're ready.
Okay. Very good. Got a good
Okay.
blood pressure.
See. All right, very good. All right, and so the pulse ox, that's how much oxygen.
That you have. And I have had occasionally, I've had a patient come in after he's had open heart surgery, and he been at home, he'd seen his home health nurse, all that was finished. He came in to start his cardiac rehab. Well, he wasn't exchanging his oxygen well at all. He still had a lot of fluid. Your oxygenation is 98%, which is great.
Excellent.
All right, and then do you want me to put you on a heart monitor?
Yeah. See how this old ticker is doing.
Okay. Well, let's see. I'm going to just put this over your head.
Okay. I want to tell you this about the pulse ox thing. You know, my son, who's almost 20, when he was born, he had issues with breathing. And I remember his pulse ox was like 60. And I mean, he was immediately hospitalized.
Yes, that's very, very low. It shouldn't be below 90.
Right. And they called it reactive airway disease. See, we mamas, we be remembering.
Yeah,
stuff.
we remember things like that. That don't forget. I'm going to put this right here under your
Okay.
shirt.
Watch all the jiggly parts.
I know, that's why we're trying not to expose nothing. And I'm going to put this one over here on this side.
Yes.
Okay.
You know, if you've got any family history of any kind of heart issues, it's very important that you are monitoring these things and getting yourself evaluated.
Right, and especially, after you've had a stent or angioplasty or any kind of heart surgery, whether it be a valve or open heart with grafts, it is important that you be monitored. Your heart can do irregular heartbeats called atrial fib, can go into have frequent PVCs, which sometimes at home, if you're at home, you don't realize what's going on. You just know you're getting short of breath. Some people will feel the palpitation, the skip. Some people don't. So this is where we come into play. If you're here and we're gradually increasing your exercise, then we're watching the monitor all the time. Somebody's there. We can always backtrack too with it, so that's good. So we're looking for those things. You will be surprised if you started off, if you did your 6-minute walk and we did your evaluation, we start you at 6 minutes. By the time you get done with your 36th visit, how much
The change.
change. I mean, you're already walking 40 minutes by then.
That's fantastic, and especially when you're in recovery, how important that is. Okay, so are you ready to get started?
Ready.
All right. we'll
Okay.
be back. All right, Miss Gwen, we are out here, and I see a bar, which I assume that my leg is going to have to go up there.
No, ma'am. And it is a dry bar, too.
Perfect, perfect. So tell me what takes place now.
What we're going to do here, after we've done our 6-minute walk and your first session, real exercise session, we come in, you do 2 laps around the pool, and we're going to show you some stretches that we're going to want you to do at home twice a day, once a day on the days that you're here,
And so how many times would a patient come here?
3 times a week.
Okay.
Minimum of 2. We do our exercise on Monday, Wednesdays, and Fridays. And if they're out of town, they'll pick 2 days
Okay.
of those.
Okay. And so you've got me hooked up to a monitor, so Kelly and Lindy, they actually can tell that my heart rate is,
It's
going.
beating over there.
that I'm alive.
And because you're talking to me, I know that you're okay.
Okay, okay. Very good. All right, so what kind of stretches?
So what we're going to do is you'll face the bar, and then what you'll do is I want you to first take some slow, deep breaths in through your nose and out through your mouth.
Okay.
And then we do some shoulder shrugs.
Okay, you'll hold that.
Okay? We'll do that about 5 times.
Okay.
And then we're going to do shoulder shrugs. Put your hands at your side and just go up with your shoulders and down. This just gets you limber. Limber up, relax. This exercise is relaxing. It does release a lot of stress. And if you don't believe me, just see the faces on these people when they come versus when they leave us. They come, they're dreading it, their first couple of visits, and then by the time they are finished, they're smiling.
Oh, that's awesome.
All right.
Okay.
Okay, so after we've done the stretches, we send this card home with them
Okay.
to do. And then we're going to start
Right
you.
here,
Yes,
the
ma'am.
modified warm up and cool down. So that's something
Right.
that the patient can do at home.
At home.
Okay, very good.
And then here, we always show you how we clean our equipment between each patient's use, okay? So you'd spray that.
Spray this.
Yes, ma'am. And you wipe the bar down where you were. And then we're going to go to the treadmill.
Treadmill. All right. All right, so we're headed to
Okay.
the treadmill.
Treadmill. It's right over here. I'm going to let you get up here. That's the elliptical. This is the treadmill. Now, safety first
You're
for our
monitoring my
patients.
heart over there, aren't you?
Safety first. Always put your clip on.
Okay.
And what we're doing today is your first day here. So what we're doing is just to get you through, just to show you what you're supposed to do.
Okay.
So when you're on the treadmill, you don't have a death grip. You relax. Just
Like-
relax.
like
okay. And what I'm going to do is I'm going to hit the start button.
Okay.
And the machine's going to count 3, 2, 1 and start moving.
Okay.
So when it starts moving, your feet need to move, okay?
Yes.
All right.
I want to ask you, like, what age range of patients do you normally have?
We have a variety. We have, from right now, we have 40-year-olds to we have 90-year-old in here.
You know what's amazing is that you offer so many great things to help people heal. You know, because years ago they didn't have all of this type technology and different things.
Right, right. Like I said, it's amazing to see these people. We've got 30 and 40-year-olds that are having cardiac arrests at home. They're coming in, they get their stent, they go home a couple of weeks. If they've got a stent, we can start them after 2 weeks, and we get them in here and getting them back to a normal life.
At that age.
You can live well with heart disease.
Okay. Very good. All right.
Now, since your feet are moving,
My feet are moving.
I'm going to increase the speed a little bit.
All right.
Now-
You know I can handle it.
Okay.
That machine just better be ready to catch the spot.
And we're just going to do a little bit today.
Okay.
We're not trying to stress
I'm not gonna
anybody
sweat,
out.
though.
No.
But that's the key.
Not today.
Not today. But otherwise, be sweating.
Yeah.
Okay.
We'd be sweating if you stayed with us. We would increase it.
And so this is usually about a 2-hour visit.
No, Each session after the first.
After the first.
Evaluation, it takes about an hour.
Okay, so the first initial evaluation is the longest.
Yes.
Because of everything you have to do.
And then it's about an hour session, 3 times a week. And we also include education in that
That's
as
good.
well.
That's good.
Talk about cholesterol, diabetes, how much should I be exercising, how do I know if I'm pushing myself too hard.
Right.
We talk about diet. We have a pharmacy class and a nutrition class.
That is
And
fantastic.
Yes. So, I mean, we
That is
cover all
wonderful.
the boundaries. And we give you the guidelines to take home to use, and that's the goal of cardiac rehab,
And
is
that's
to
the thing.
continue your exercise.
And that's the thing, people, that you have to continue it at home, because they're definitely doing their job here with giving you the tools that you need necessary to live a long life.
Right.
And so it's necessary for us, the patients.
We give you the tools. Well, you do well usually here, and then we always, when we get finished with our cardiac rehab
Yeah.
program here, we do have a couple of options. Like you can stay in our maintenance program for 2 months, and that gets you so that you're a little more independent.
Right.
So you can go to the fitness center or a fitness center, preferably ours. But anyway.
So is there anything else that you want to make sure that the people out there understand about cardiac rehab, the job that you do, the process of what it takes in the rehabilitation?
Yes, please make sure that your physician is aware of our cardiac rehab program. They have been sent information, and we have talked to them, but remind them and tell them that you are interested. Come
Okay.
on in, take that initiative as well.
Yeah.
We can contact them, we can get the order, we can get you in here. It's not hard, it's something that's going to help you live longer.
Absolutely. And you know what, and that's the goal. So we definitely appreciate you, Miss Gwen, all of the ladies and the men here that are here at the cardiac rehab facility, everything that they're doing for the patients. And of course, you see some smiling faces here. These people are working it out.
Yes, we do get called with the whips sometimes, because we increase their workload every week.
Well, sometimes
something every week.
you have to crack the whip. You know how we get so hard-headed. Thank you so much.
Thank you.
Ladies and gentlemen, this is Miss Gwen Upshaw, cardiac rehab nurse here at Fairview Park Hospital, and this woman is awesome.
I'm ready for you. Come on.
But I'm getting tired already. Thank you. Okay, Miss Gwen, what am I going to do? Am I going swimming or what?
No, we're not going swimming. We have our heart monitors on, and they're a little expensive, so we don't go swimming,
Gotcha,
okay?
gotcha.
So what we're going to do now is a 6-minute walk, and you'll walk at your pace for 6 minutes.
Okay.
I've got a timer, and
Okay.
I'm going to count how many laps we go.
That I take. Okay. Now, this class that's going on here, this is like an aquatics class?
Yes, ma'am.
Okay.
And we just go around that. Just be careful of any water that may
Okay.
be on the...
So no jogging, just walking, just to
Just
test how
walking
the
at your
heart is
pace.
going. All right, we ready?
And to see if you have any shortness of breath, any chest pain, or any joint pain.
Oh, I'm
So
sure
that
I will.
tells us what we need to start on.
You're gonna,
We're
might
here
have
to
to-
help you, not
yeah,
to harm
I
you.
know, but you're going to realize my joint pain in just a moment. All right, so I'm going to go for a walk just to
Okay.
test. Okay,
All right.
all right, we're back. Hi everyone, we are featuring nurses and just really wanting to talk about the amazing work that they do here at Fairview Park Hospital and within our community. We've got Ms. Danielle Davis here. We're on the surgical unit at Fairview Park, and of course you're orthopedics, is that right?
That's right.
And of course, you know, Danielle, you've been a nurse for a little while. Tell us a little bit about yourself, and then we'll talk about why I'm in this gown and what we're going to show you in the process of what Danielle does.
Okay, I am a RN here at Fairview Park Hospital. I'm orthopedic nurse certified. I've been here about 8 years on the surgical unit. I am also the clinical coordinator, kind of like the assistant director of the surgical unit.
Okay.
I am married. as of 2 years now.
You're still a newlywed, Danielle.
Yes.
Congratulations.
I don't have any kids,
Mm-hmm.
just a little puppy dog at home,
What's the puppy's name?
Lulu. She's actually a Labradoodle.
Labradoodle. How cute is that? All right. So you're kind of busy, right?
Yes.
Tell us about the work or the different patients that you see on this unit.
We see lots of general surgery patients, orthopedic patients, urology patients, anything kind of like that. And then we'll also get some medical overflow as well.
And so what you work with specifically are people who've had orthopedic surgery, correct?
Mainly. yes.
Mainly. Okay. And what type surgeries have you been working with patients?
Total joint replacements, or like total knee or total hip replacements.
You know I'm going to need one of those. So this is going to be personal information that I'm going to need. Go ahead.
And we also do some gallbladder surgeries, gallbladder removals, hernia repairs, just general things like that as well.
And very good. And so, and it's very delicate, when you're talking about people having the surgery and then the recovery process of that, we're going to go over what happens after a total knee replacement, correct?
Right. We're going to go over what will happen the moment you come into the room from the recovery room.
Okay. All right. Are you ready?
Yeah.
Okay. All right, ladies and gentlemen, we are back, and we're going to show you, at least Danielle, she's going to show you the process of what takes place after a patient has a total knee replacement. Are you ready, Danielle?
Sure.
All right, let's go.
Okay, so the first thing we're going to do would be I would come in and get report from the recovery room nurse, which would be like a handoff. They'll tell me about your surgery, what you've had, and what's been going on.
Okay.
And then I will do my post-op assessment and set up all your equipment and get your vital signs and things like that.
All right, explain to me, explain to everyone out there to what's going on right now with me.
Okay. You have just come back from a total knee replacement. You've had your knee replaced. And you've had a spinal block, usually, is what they would do, and that means they're going to numb you from the waist down so that you don't feel anything for a few hours after surgery, which is really good. That gives you time to get that knee moving, get the motion in it before it starts coming back and you're feeling some pain.
Okay, I've had a spinal block. They're great until they wear off.
That's exactly right.
Okay.
That's exactly right.
All right, go ahead.
So the first thing I would do would come in and we'll start getting your vital signs.
Okay.
So I would hook you up to this machine. This vital sign machine.
And the patients, are they cognizant at the time when they see you?
They usually are very alert when they come in. Since they haven't been put fully to sleep under general anesthesia, they're usually pretty much awake.
Okay.
So we would let the blood pressure cuff take, and we'll get all your vital signs, your temperature, your heart rate. We'll enter them into the computer. We'll keep a record of that. We'll check them about every 15 or 20 minutes. For about 3 hours, just to make sure there's no complications after surgery with that.
Okay.
Once we get that going, I would start my assessment. I usually do a general head-to-toe assessment. You'd have IV fluids. I would check that out. I would listen to your heart, lungs, and your stomach, just your sounds, just to make sure things are working right.
Okay.
I would take a look at your incision. You have an ice pack on now. So I would peek at it, make sure there's no bleeding or drainage. I would hook you up to these machines. These are really good. They promote circulation, prevent blood clots. It's called a SCD pump. And they'll hook up and they'll massage your legs kind of. And it's kind of like artificial walking. It prevents blood clots, which is a really big risk after this type of surgery. You want to make sure you're moving your legs and getting that blood flowing through those veins and arteries. You would come back with a Foley catheter, and we would monitor your urine output for the first 24 hours. Sometimes you might come back with a drain that's going to drain that drainage out, and we would empty that and monitor that. And those things would be taken out the next morning, so you'd keep them overnight.
Very good. Now, this is what there's certain things that I know from having had knee surgery several times. And tell them the purpose of, like you say, you've got the drainage tubes.
Right. You'd have the drainage tubes. And once you've had your knee or any joint cut open and replaced, you have a risk of bleeding. And there's going to be some, but we want to make sure we monitor that. And the best way to do that is usually put in a drain so we can see how much is coming out.
And so if a patient is in here after knee replacement, how long are they in this particular unit?
2 days. 2 days. They'll go home in 2 days. Yep.
And do you have other nursing staff that also work with you concerning like one patient that had?
Yes, it's very, especially orthopedics is a very collaborative nursing thing. We rely very heavily on physical therapy, occupational therapy, and then we also have nursing assistants to come in. So everybody will be working with you all day long, getting you up, walking you. Sometimes all of our patients will come back with a CPM machine, which is continuous passive motion. It's going to move that leg back and forth, get that knee moving just to prevent it from stiffening up and making sure your joint flows like it's supposed to.
And so how long after this particular surgery, which is a total knee replacement, do you have your patients actually up and walking where you actually take this off and say, okay, we need you to start walking now?
That same day, that afternoon. That's our goal. That afternoon to get you up and walking in the hall.
I can't tell you how many times I've cried.
It feels good to get out of the bed, and it's good for you.
That's what you all say, but it is true. It is good for you. But the last surgery I had was a Fulkerson tibial osteotomy where they broke my bone, shifted that, to kind of take the knee, the pressure off the knee. But just the recovery for that was 12 months.
Right. Any type of joint, bone, anything, it's in at least a 6 months to 12 months recovery period. You've got to let that thing heal.
And how important is it that they are, that the patients follow the procedure, not just what you're telling them to do, but, after they leave here, there's continued care.
There is. And we'll send you home with home health care, physical therapy. They would come 3 times a week, and nursing care to monitor your wounds and things like that. And you'll go home on a blood thinner because blood clots are a really big risk, like I said, after this surgery.
And so how many patients, is this unit normally full? Do you have a lot of patients?
Our census in patients varies. It goes up and down, but we mainly keep, we have a 16-bed unit. We mainly keep about 8 to 12 patients is our average, I would think.
And so you talked about the partnership to where you all collaborate in different things. And so the knee replacement, you do have the physical therapy.
Right.
Now, what do you think about the aquatics therapy for the joint recovery?
I really haven't had much education or knowledge in the aquatics. I haven't seen very much of that at all around here. And really with joint replacements, you don't want to be getting those wet and submerging them in water. So that wouldn't be a very good thing for that. But maybe some other type of like acute injuries, like that would work.
But aftercare, I'm thinking like down the line, once you've healed. Like I've had...
For therapy-wise, once your incision heals, I think that would be a great exercise. It's low impact. And
That's what I was
it
gonna
gets
say.
it gets you moving, and it's kind of more comfortable on that knee.
And when we talked about in cardiac rehab about just the age of patients, age range, when you're, in your profession, in your field, does your age range vary with the patient that you see?
It does. Typically, they're in about 50 to 70, 80 sometimes years old. So it just really depends on how bad their knee is and how long they're willing to wait for it to.
Well, I'm in my 40s, and I was told I was pretty young for a replacement. Right. Thank you. That was encouraging. But, so what age range would you say is a good age range to have your knee replaced? Because I always think about this, like to have it at a certain age so that you can actually enjoy your life afterwards, to be able to walk around and run. It
really just depends on the type of reason why you're getting your knee replaced and how healthy you are in general. So age really, an 80-year-old can do just as good as a 50-year-old depending on their motivation and how well they want to do and how well they were doing before the surgery.
And they talk about, the recovery from a knee replacement is very extensive. And I know people who've had to have both knees replaced. Right. And so, but they do one at a time. Do you see that that's a better recommendation than both?
I definitely do. One at a time seems to be a lot better because you can focus on that one knee and that one recovery and getting it done that way.
And and so much has changed now with the different material that's used from knee replacements and the technology.
It has.
So, I would think it's wonderful. Of course, you guys have the best around here.
We do. And we also can do the anterior hip replacements, which is kind of a new and upcoming technology. The recovery time's less, there's less pain, so that's a really good thing that we can offer here for that.
And you know, the vanity of a person talks about the incisions. You know, well, I don't want a huge scar. I don't. You know, do you find with knee replacements how is the scarring on that one, the incision?
Well, since you only stay with me about 2 days, I really can't say what the scar would be like, because I don't usually see them unless they come back for another knee replacement, which we do have a lot of people that come back to have their second ones replaced. So, but I would think the scar is just going to be.
It is what it is.
Scar.
It's like your you know, your battle scar, you know,
Right.
it's like, you know, and so for that, it's all worth it when you find the results in the end, to where you're able to walk, where you're not, you know, your pain is not as, you know, as much as it was, or if any pain afterwards.
That's very true. That's very true. I was walking through one of the physician's office yesterday, and I heard the patients waiting, comparing their staples. How many staples did you have? Well, I only had this many, and well, your incision looks good. You know, it was kind of neat to hear them kind of joking around
The
about
things that interest us
it.
nowadays.
I know it.
All right, now tell us, is there anything in particular, Danielle, that you want to make sure that the people out there understand about the work you do as a clinician in the surgical unit, and two, for patients? Anything you want to make sure that you reiterate on, or to make sure that you say, so to make them understand about what you do?
Well, we're just here to help our patients. The biggest joy I have is when my patients come back to see me, someone that's had a very traumatic, maybe fall and broke their hip, and they go over to our rehab unit, and they walk around the hall, and I see them walking with barely using a walker. That just kind of warms my heart. That tells me what I'm here for. I'm here because I'm getting them better and getting them back to life.
And that's what it's about.
That's exactly what it's about.
And we certainly appreciate you, Danielle, and all of the other nurses that are here, and the doctors within the surgical unit, orthopedics, and what you do to help heal.
Oh, well, thank you. It's our pleasure. I really enjoy it. So.
Only complaint I have is this gown. Otherwise,
Maybe me and you can come up with something to be a little better for
yeah,
that.
we have to design something else, because you know, all your goodness gracious hangs.
That's right.
Thank you. Ladies and gentlemen, this is Danielle Davis here. She's a certified in orthopedics here, the clinician here for the surgical unit. Thank you for everything that you do, Danielle.
Thank you.
All right, I'm going to rest here for just a little while longer. Danielle Davis, everyone. Hi, everyone. We are definitely being very informed here at Fairview Park Hospital, and we are here at the Cath Lab with two of their amazing nurses. We've got Scott Gray. Gray. They call you Scotty, right?
Scotty, yes, ma'am.
Very good. Love the camouflage.
Thank you.
All right, and we have Christy Runyon.
Yes,
How are you, Christy?
great.
Now, listen, guys, what we want to do is we want you to kind of tell everyone a little bit about yourself, because, you know, we've been meeting so many nurses in so many different areas. And, of course, we're here in a specific area here with what you do in your profession. And so, but we want to learn a little bit about you first. All right? Ladies first. How about you, Christy? Tell us about yourself.
I am Christy Runyon. I work here in the Cath Lab at Fairview Park Hospital. I am married. I have 3 kids, 8, 6, and 2 years old.
You go, girl.
I received my RN from Middle Georgia State College. I've been a nurse for 2 years.
Very good. And so you're in a very, this position and the work that you do, I'm looking around here, this is some tough work that you're doing.
Yes, it is. Can be.
But you're enjoying what you're
I
doing.
do. I love what I do.
How do you keep balanced? You know, you've got 3 kids, a husband, and you're working full time. How do you keep the balance? How do you keep things going? You just find a way, right?
Yes.
You just find a way. Because, you know, when you're talking about 3 little kids, and then, of course, the work that you do here, you've got to find a way to kind of balance it all to make it all work.
Yes.
All right, Scotty, we'll go to you. Your turn.
Yes, ma'am. My name is Scotty Gray. I'm been a Cath Lab RN for a year and a half now. I went to Georgia College and State University, and I've been an RN for 8 years, 7 or 8 years.
And you're a dad, too.
I'm a father. I have an 11 and 15-year-old, 2 boys, and married and loving life. Enjoy what I do.
Very good, very good. Go Bobcats, by the way.
Go Bobcats.
You know, and as I was asking Christy, you know, with the work that you do and being a family man, how do you keep things together, you know, and what do you do on your downtime? Or do you have any downtime?
We have the occasional downtime. We pull call there's somebody on call 24 hours a day, 7 days a week, but we rotate the call rotation, and I hunt, fish, I do the things most people do. It's
By
just-
looking at what you're wearing, I think everyone out there can guess that you've got a rifle or a shotgun somewhere at home.
I'm a couple of each, probably.
Very good. Christy, now what do you do for fun?
Spend time with my kids.
There you go, honey. There you go. Enjoy it now.
Yes.
When they become teenagers, they have their own life. You know that. Definitely, right? You know. All right, well, let's get into the specifics about what we do here, what you do here, and kind of describe some of the things that we're seeing here. And I'm actually going to be a patient for you today.
Okay.
All right? We'll start with you, Scotty. What do you want to talk about?
If you're coming in with a heart attack, our priority is save muscle. We want to come straight from the emergency room to the cath lab, and our goal is 60 minutes door to balloon, which means from the time you get here to the time we actually blow a balloon up and open up the artery is 60 minutes. National average is 90 minutes, and right now we stand at 55.
That is outstanding.
Yes.
That's outstanding. How intense is it? I mean, of course, there's no one in here now, but how intense is what you do?
It can be very intense at times. Sometimes things,
Because when you talk about, when I say that, it's like if a person has a heart attack, so they go from the emergency room,
Yes,
right?
ma'am.
And then they come here to get the catheterization.
yes,
And just from, in my mind, that's intense.
yes,
Our number one priority is patient comfort. Pain is a major factor as far as heart attacks go. We will prepare the patient in the emergency room if we have time. If not, we have prepped them on table. And,
On the table.
And get everything ready. And we have had door to balloon times as low as 27 minutes at times, just depending. If we're here, it will be that low.
You guys are machines.
I would say it's a well-oiled machine most of the time. If it's 3 o'clock in the morning, it may not be that well-oiled, but we are still a machine when we come in because we just work well together and put everything together well.
And that's good. And you say you have, someone's on call, 24 hours. How many people
Yes.
do you have on staff in this department?
we have, no, I'm trying to think.
Because
It's 9
We have 5 nurses
nurses
and 4 techs.
and 4 techs. It's 9 or 10 full-time staff, and then we do have part-time employees also that will fill in as needed. And our call team is 4 people, and then the cardiac doctor is the 5th as part of the team.
And so when a person comes in here, they're in pain,
Yes,
excruciating pain.
yes.
How do you keep them calm? Because a lot of times people, the adrenaline is flowing.
Yes.
What do you do to keep the patient calm?
Talk to the patient, make sure you explain everything well to them, help them to anticipate what's going to happen next, and just try to be there for them and answer all the questions that they have.
Are they always compliant?
I would say.
I mean, you say that because, when I'm thinking about a scenario, when I say are they always compliant, meaning the fear of the unknown that a person may be experiencing.
I think one of the hardest things we deal with is the people who the pain will overwhelm, and we have to educate them. You have 2 options. You need to get on this table and do what we say, or the other option is not a good one.
Right.
And we will educate people to that aspect of what's going on, and a lot of times that gets them in the right mindset to comply with us.
Well, because it really requires you all to be, for one, to know exactly what you're doing, to be skilled in what you do, to be patient and be calm yourselves, because you're still human. And, and with patients coming in with different situations and you're not quite sure how their attitude is or what they're feeling, and of course dealing with pain. Not everyone handles pain as well as others, if that makes sense. And so you guys have to have a threshold of calmness yourself in this situation.
Yes, I agree.
Having 3 little kids, that helps you.
Yes, I have lots of patience.
And having teenagers, at least one
Definitely.
teenager.
Definitely.
All right, so what are you going to show the people out there by using me as your patient as far as the process?
We're going to, if you'd like to get on the table, the process as far as the nursing aspect goes is more of preparation with sterile drape. We actually shave groin. which I know you don't want that in this.
Yeah, this is not that kind of TV, so y'all, sorry about that one.
But we actually
yeah.
prep the groin
Right.
for sterility and
Right.
don't want anything going into the major artery that goes. And we drape the patient for sterility and cleanliness. Don't want any infection because it is
That's
a major
good.
artery.
And you know, when you talk about cleanliness, and too, let's talk about what you have on too.
Yes, ma'am.
Explain that to the people about what you're wearing and why it's so important, because safety is very important with this,
Yes.
correct?
Correct.
And so, tell us what you're wearing, Nurse Scotty.
This is actually a lead apron. They come in many different designs. Of course, the camouflage was my choice. The apron is to protect us from the radiation used during the procedures. The radiation has been known to be a cancer-causing agent, and we're protecting our vital organs. And I actually have a thyroid shield to protect the thyroid also
Wow.
from the
So,
amount of radiation that we use.
so anytime you are in the operating room,
In this room.
in this room, you have to have this on.
If we're using our eye, the radiation, and it's not that it exposes the patient to an enormous amount of radiation, it's that we're in here so much, we need protection so
Right.
we aren't overexposed to the radiation from the amount of time we're in.
Okay, and so there's a lot of computers around here. Tell us about we saw a lot of computers as we walked in. I mean, you know, are those like monitors? Are they like, tell us about that.
They're monitors, the TV screens you see in front of us are,
There's like 6 of them.
one of them helps us see what's going on with the patient vital signs wise and all of that, and the other ones actually record the images we take, and we can see them as soon as we take the images. We see them in here.
Technology is so awesome.
Yes.
You know, I'm a little intimidated by the room just from being in here.
It can be. The first time I walked in,
Oh,
it
it
was.
creeps
it
me
was-
out. You know, I had to get myself together to come
This-
in here
this
because
is
it's
somewhere
like,
you
this
don't
is.
wanna be.
No, it is. I mean, you think about that, you know, because I think about my family history, you know, of heart disease, you know, and heart attacks, and so, and I know I have family that's been here, you know, so it does kind of touch home, and it does kind of give you a certain kind of feel. So, all right, so I'm going to get up on the table, and you guys are going to talk us through about what you would normally do with the patient, right? Okay, be right back. All right, ladies and gentlemen, Scotty and Christy are going to kind of talk us through about the process of what takes place at this point in patient care. All right, guys, take it away.
Okay. So if you come in for a STEMI through the ER, the first thing we're going to do, you'll actually be on a stretcher. We would wheel you in this room, and it would probably take 4 of us. We would actually lift you onto this table. Okay, and then at that point, everything's going very fast. We always tell our patients to bear with us that things are going fast, and we try to explain everything to them, you know, as everything is going on.
So I've got a question. So the patient is cognizant, like they're aware of everything that's going on, but they just may be a little like upset or whatever, or in pain.
Yes.
Okay, go ahead.
But there has been situations where you may have a patient that is unresponsive, so
Oh, jeez.
not often, but
Okay.
And from this point, we would get the patient prepped. The cath lab techs, who are the ones who are at bedside with the doctor, will get patient sterile, make sure the groin is prepped and everything is set up like it needs to be for the procedure. And the doctor will be letting us know what we need to do as far as medications. Sedation and relaxation medications are a big factor for heart catheterizations because you want your patient still and relaxed during the case. And some will sleep throughout the case, others are awake, but a lot of times with the medications we use, they don't remember what happens.
Okay. So the preparation of the patient with what you're doing, the lowest time has been in like 20-something minutes?
Yes, ma'am. That's when we're in the hospital and they call a code STEMI. We're in the ER waiting on them when they get here.
Okay, but normally it's about an hour or so?
55 minutes is where we stand right now on our time frame. National goal is 90 minutes. Our goal is 60, and we're below the 60-minute mark now.
And you know, you talked about, Christy, how you said that like some patients are unresponsive. They're unconscious when they're in here?
Sometimes the pain factor will make them, and other comorbidities, which are other things that are wrong with the patients besides the heart, can make them unresponsive. And in that case, sedation and relaxation is not a major factor. The major factor is just getting the vessel open and perfusion back to the heart muscle.
You know, ladies and gentlemen, this is, you know, just from hearing them talking and the fact that I'm under here, this makes me real nervous right now, you know?
I can see it.
This is really, because when you think about how serious this is, and how serious what you do is, and how critical it is that you know exactly what you're doing, that you're precise in what you're doing, because this could mean the life or death of a person, okay? And so I think when I'm lying here and I'm like taking it all in and looking at those monitors, if you can see those monitors where, of course, if this was an actual situation, you'd be seeing all kinds of things, right?
This monitor bank, actually, this one is where we would monitor our vital signs, and normally it's actually on the other side of the table and the physician is here, and we're usually at the head of the bed, but we can see vital signs, and the images we take, we see here. And as I was saying earlier, they're instantaneous. We know exactly what's going on, and catheters and wires and all of those things we can use to get past a blockage and open a vessel up with stents and balloons. So there's a lot of stuff and a lot of things going on normally if this was a live situation. Yes, ma'am. It's you were saying earlier, a well-oiled machine. It looks that way a lot of times, and a lot of times it's organized chaos. But even with that, though, you see just how professional you are and how good at what you do, your craft, you know, because you have to. And, you know, and people, we just want you to, we're hoping that you're understanding just how important the jobs of the nurses are here and in the different areas, and that you're saving lives every day. Yes, ma'am. The rule of thumb, Christy, I, and the other nurses that work here, and the rest of the staff too, I think our rule of thumb is we take care of our patients like we would want our family taken care of, and that way we know we're not doing them any wrong. Absolutely. And it makes it easier for us. I may see a gentleman who reminds me of my father, that kind of thing. It makes it easier to do what we do. The training we've received over time has just made it where things come together without you having to think about it a lot of times. Right. And I'm lying here thinking about, because my brother-in-law recently had a heart attack, you know, and had open heart surgery. And so all of that kind of stuff, and just think about the patients who, given their situation, what is going on through their mind. And then you're telling them, okay, be calm, Mrs. Smith, this is what we're getting ready to do, Mrs. Smith. And then so you're still having to explain what's taking place, what's transpiring, and at the same time keeping them calm. I'm sure you've held a whole lot of hands.
I was just fixing to say that.
Throughout this.
Be necessary. We have held hands. We've
wiped tears.
We've wiped tears. We have prayed with patients. Whatever makes them feel comfortable.
Well, you're probably going to have to wipe my tears because I'm getting a little emotional over here. But we want to thank you all for everything that you all do for the individuals here in the communities, how you really care about what you do. You're good at what you do, and people are walking away from this knowing that they've been in good hands. Yeah.
Thank you.
Christy, thank you so much.
Thank you.
Thank you for everything you do, because you're a mom. You know, you take care of your family, and you also take care of our families. And Scotty, big guy, thank you for making me feel relaxed on this table, even though I was crying.
Yes, ma'am.
But just thank you for everything you do, the professionalism, the warmth that I felt, and of course that they felt. We are so proud that you all are a part of our community and the things that you're doing.
Thank you
so much.
All right, ladies and gentlemen, we hope that you have gained some knowledge and an understanding of what takes place here in the different areas here at Fairview Park Hospital. That's all the time we have for Real Talk, and please, ladies and gentlemen, please keep watching.